Dr. Saad, most of our people have already joined, so actually we can start now and rest of the people can join us later.
ठीक हो
Dr.
गया
Saad?
मैं करूँ
All right.
start फिर
Right. So, actually, the format of our presentations is that we usually hold it in English because most of our participants, some of our participants are from other countries like Nigeria, Myanmar, India, and other countries. So, we usually request our speakers to keep the format in English only so that the others also understand it wholly. And before you start, let me thank Dr. Sadur Rahman from Shaukat Khanam Memorial Cancer and Research Center, Lahore, to join us and giving us an insight on his topic. I'm really grateful to you, Dr. Saad. Dr. Saad is currently working as a consultant anesthetist and special care consultant, and his special interests are in critical care, tunneled vascular access, and thoracic anesthesia. So, Dr. Saad, you may start your presentation. And thank you so very much for joining us today and giving us a talk on perioperative fluid management on evidence based medicine. Thank you.
Okay. Okay, so can everyone see my slides?
Yes, we can see your slides. Thank you.
Okay, so we'll start. So thank you very much, Dr. Asma, and the PSA Karachi Forum for giving me an opportunity to talk about this very important topic for anesthetists and those persons who are working in surgical patients. So perioperative fluid management. So why is it important for us? So if you look at the left side of your screens, this movement is usually a very frequent movement that is made in OR, and that's the anesthetist that is controlling the amount of fluid that he or she is giving to the patient. And what the objectives of my talk are is kind of reinforce all of the principles of fluid management and how it affects your patient. And hopefully by the end of this talk, the understanding of the whole group, including me and all the participants, would be improved in terms of what affects different types of fluids have, how much fluid that should we give to a patient, what are the harmful effects of giving too much and too little fluids, and what type of monitoring is required in the perioperative management with respect to fluids. So we'll be talking about physiology and fluid compartments. We'll be talking about composition of intravenous fluids. We'll be talking about which fluids to give, how much fluid to give, concept of liberal, restricted, and goal-directed therapy, and how to monitor patients. And then, so the whole presentation would be about 40 to 45 minutes, and then we'll have time for questions at the end. So I don't have any conflicts of interest to declare. So we'll start off with taking you back to medical school. This is a picture of my alma mater, King Edward Medical College. And why I chose to start from here is that everyone has a concept of what we learned about the basic physiology of fluids. So essentially, our body contains 60% of water if we're males and about 55% if we're females. And about 2/3 of that water is concentrated in the intracellular fluid compartment. And there's only about 1/3 of fluid in the extracellular compartment. Further, about 2/3 of the extracellular compartment is made up by the interstitial fluid, and only about 11% or about 1/3 of that extracellular fluid is our plasma. So how did our body handles fluids is that we intake the fluid from either from the oral route, or if we've got an anesthetized patient, then the intravenous route, and then it enters the plasma. And how the body removes fluids is 4 methods. It's either by the kidneys, through urine, through the gut in the form of feces, by the lungs in forms of exhalation of gases, and from the skin by evaporation and sweat. But this plasma, and then this plasma, it kind of, the fluid filters in and out of the interstitial fluid, and the membrane that holds that balance together is the capillary membrane. And then, as we talked about earlier, the major compartment is the intracellular space, and that is separated by the cell membranes. And essentially, whatever fluid we give, our ultimate aim is for that fluid to reach the intracellular space. So what are the factors that affect the movement of fluids from the plasma and then to the interstitial fluid and then the intracellular space? Is basically your cations in the plasma, your sodium ions, and your plasma proteins. The interstitial fluid is devoid of plasma proteins, but it contains the same amount of electrolytes as are contained in the plasma. And when you come to the intracellular space, the major cation that holds the fluid in place is potassium. And on the left side of the figure, the water, lipids, and gases, they are usually freely movable between these membranes. So we talk about the composition of the fluid compartment. So essentially, plasma contains sodium chloride, bicarbonate, and protein anions, and then separated by the interstitium via the capillary wall, you get your sodium chloride and bicarbonate, and the interstitial fluid is, under normal circumstances, devoid of protein anions. And if you look at the intracellular fluid compartment, the substances that make it are potassium phosphate and the protein anions. So this person, Starling, gave us the concept of movement of fluid from the plasma to the interstitium and the factors that affect that. So the major factors that affect the movement of fluids from the plasma to the interstitium include the hydrostatic pressure and the oncotic pressure. And if we look at the cell membrane, so the cell membrane is composed of the lipid bilayer. So essentially, lipids can move in freely from inside the cell, and so can the inert electrolytes. However, the electrolytes and the proteins usually move through this cell membrane with the help of ion channels or ligand-gated channels. So fluid is regulated. There are a number of processes that regulate the fluid in the body. So there are a few hormones, for example, the antidiuretic hormone, which acts in the kidneys, the atrial natriuretic peptide, which is secreted by the heart, the renin-angiotensin-aldosterone system, and other factors, including catecholamines and corticosteroids. But the major factor that regulates fluids inside the body is the thirst mechanism. So it's the brain actually measures the osmolarity of the fluid inside it and activates the thirst mechanism based on that. So what I tell my residents is that if you've got an awake patient, fluid management becomes very easy, because the patient can actually tell you if they're in a fluid deficit by just telling you that they're thirsty. So to understand what happens in the perioperative period, it's important to know what happens to our fluid balance during periods of stress. So the corticosteroids that are secreted, they retain sodium and excrete the potassium. The ADH, it retains water inside the body. The and in cases like sepsis, there is increased capillary permeability and leak from intravascular to interstitial compartment. So again, and then we have got systemic processes like heart failure, cirrhosis, kidney and brain injury. And all of these pathologies, they complicate the delicate balance of fluid compartments. So after moving on from the basic physiology of fluids, I'm just going to briefly talk about the types of fluids that we have and what are the effects that that all of these fluids have got. So this person, the father of normal saline, 1831, this guy, William Brooke-Shaughnessy, invented normal saline in 1831. So he used the term normal because it was thought that 0.9% was the concentration of salt in human body, in human blood during the experiments that were conducted. So, but if we look at the composition and compare it with plasma, so the concentration is quite different from that of plasma. So basically, sodium 0.9% saline is composed of high amounts of sodium, high amounts of chloride. It's got a high osmolarity, and I think it's very important that it's got a fairly low pH as compared to the extracellular fluid. So next we come to Sidney Ringer, and this guy in 1880 developed the Ringer's lactate. In 1930s, this solution was modified by Hartmann to treat acidosis, hence the term Hartmann solution. So it's thought that this is very close to the composition of plasma. But again, if you look at that, there are fair differences. So it's got a low sodium content as compared to plasma. It's got a high chloride content. It's got lactate in it. In place of bicarbonate, pH, although better than saline, has still lower than plasma, and it's slightly hyposmolar as compared to the normal plasma osmolarity. And then we've got our dextrose containing solutions. So essentially, we've got 5% dextrose. It only contains 50 gram of dextrose in 1 liter of solution. Again, it's got a low pH and a low osmolarity. And if you're using dextrose half saline or dextrose 5 normal saline, again, none of these solutions have got the same composition as that of extracellular fluid. And they've got differences in pH and osmolarity as compared to extracellular fluid. So plasma light, so it's a solution that's available in not in Pakistan but in different countries. It's a synthetic solution, so it's expensive to make, but it has got the closest electrolyte distribution if you compare it with all the other solutions that I've just discussed. And finally, the colloids. So the thing to remember about the colloids is these are high molecular weight compounds. That these colloids, they're formed in normal saline. So they've got different osmolarities and composition as compared to the extracellular fluid. So the first thing that we need to know before we go to the perioperative fluid management is what effects do fluids have on a normal human body. So there have been recent studies that have looked into what happens if you give fluids to normal healthy individuals, and what are the effects of it. So as you can see that giving fluid it's not like you're just drinking glasses of water, and it affects the body in different ways. So all IV fluids, when given to healthy volunteers, have shown significant decreases in pulmonary function. And if we could talk about saline, it causes a decrease in renal blood flow velocity, decreased renal cortical tissue perfusion. It decreases the body pH by 0.06, which is not surprising considering the pH of the overall solution. And it decreases bicarbonate and increases the sodium and chloride load of the body. Ringer's lactate, thought by many to be very safe to use in individuals. It decreases the pH by 0.03, increases bicarbonate, it lowers the sodium and chloride. However, what effect that is properly attributed Ringer's lactate is, would giving Ringer lactate increase the body's lactate? It does not cause an increase in the lactate of the body. So the major question that comes to mind after getting to know about composition of fluid is, what fluid should I give to a patient? So the answer to that is, again, a question that why you are giving intravenous fluids. And there are a fair number of reasons that you give intravenous fluids. We never give them to a normal fluid. So you're either giving it to resuscitate a patient, we're giving it for replacement of losses, we're giving it for maintenance. So giving it at a time when the patient cannot control their fluid intake. We're giving it to redistribution. So, a lot of times the fluids is redistributed from the extracellular fluid compartment or the intracellular fluid compartment, and it's not in the right compartment. So you need to know the physiology of what is happening to the patient, and then give the intravenous fluids to counter this redistribution. And for these 4 hours, I think it's important that when you're giving, if you're looking for a reason, then you need to reassess your patient. Does this patient need intravenous fluids, or can this patient do without fluids? So coming to fluids for resuscitation, we either give it for two main reasons. Either the body is losing fluid in the form of blood. So if there is surgery going on and there's blood loss going on, active blood loss going on, then you need to resuscitate this patient. Or the body is losing fluids in the form of evaporation. So whenever you've got an open surgical field and the tissues are exposed, a lot of fluid is going to be evaporated from these surgical sites. So this is all fluid loss. So this is not fluid that the body can just replace. So you need to resuscitate these patients for this. And the next are the fluid shifts. So why do fluid shifts happen in the perioperative area? It's either due to vasodilatation. So there's a lot of so some of our capillary beds, they go undergoing vasoconstriction because of increased catecholamine levels, increased norepinephrine due to stress response of surgery. There is increased capillary permeability. There is inflammation due to tissue handling by the surgeons, and all of these, they lead to a neurohumoral response leading to cytokine release. So the major effects that are happening are, there's vasodilatation going on and there is increased capillary permeability going on. So resuscitative fluids are always given as a bolus in the intraoperative period. And what would you define a bolus? So there's no concise definition of bolus. For adults, some authorities have defined it as 500 ml of fluid over 15 minutes in adults. For pediatric population, it's about 10 ml per kg. However, the rule for giving resuscitative fluids is that you replace like for like. So if you've got blood loss going on, the best fluid to give is actually blood. If it's evaporative losses or redistributive losses, then you need to give the appropriate fluid for that. So either it's crystalloids or some other fluids. So I'll talk a bit about resuscitative fluid and the type of fluid that is used. And if you come to resuscitative fluid, if you look at the world over, saline is the most commonly resuscitative fluid used. And most of the work done on saline hasn't been done in the perioperative period. I'll come to the studies that have done that, but it's been mostly done in populations in ICU and in emergency room. So what have been the recent trials that have been done? So the major trial that was done in 2015, the SPLIT trial, it's about 2,300 patients. They compared saline and plasma light in critically ill patients and found no difference in outcomes. So all of these trials that I'm going to mention, they're looking at major outcomes after after giving these type of fluids. So SALT, this was an original trial that was done in early 2010 to 15 period, and patients received balanced salt or saline solution. And what they found was that the incidence of death renal replacement was higher in the patient that was given saline. So the two recent trials completed in 2018, the SMART and the SALT trials, both contained more than 10,000 patients. So SMART was done in the ICU population and SALT-ED was done in the ER population. And what they found was that the incidence of major adverse kidney events, so this is MAKE, the abbreviation is used for that, they were higher in the saline population. And the SMART trial that was done in ICU population showed there was a higher rate of renal replacement therapy and death in patients that were given saline. So although these are very large trials, what they are adding to the body of literature that saline, if you give large amounts of saline, it can cause higher incidence of renal injury and possibly death. However, I wouldn't want all of the participants to take back the message that that saline is something that is harmful for the patient. You can give saline. These are large trials. So, SPLIT trial was 2,000 patients and it actually found no difference. But what you must know is that if you're giving saline to a patient, what are the effects that are going to occur in that patient? So the first term, the term abnormal saline, has been used for some time now, and researchers know that actually saline is not a normal solution, it's actually an abnormal solution. And if you give high amounts of saline, it can lead to hyperchloremic metabolic acidosis. It gives a very high chloride load, which leads to renal vasoconstriction, and it can lead to acute kidney injury and more need for renal replacement therapy. However, the large body of studies that have shown that there's not much difference in mortality if you compare saline and Ringer's lactate. Again, Ringer's lactate I think, again, not a normal solution. If you give large amount of Ringer's lactate, it can cause hypotonicity, can lead to metabolic alkalosis. The calcium in it can bind to drugs and reduce bioavailability. It's got a very high level of lactate. We still don't know if that high level of lactate is harmful for the patient. And again, it has shown no benefit in terms of mortality of patients in large trials. So coming to colloids, so colloids very frequently used by some people. The advantage of them being that theoretically they've got longer plasma half-lives, so they'll stay in the plasma longer. They're not filtered out even in patients with sepsis. So even if there is increased capillary permeability, colloids stay in the vascular compartment. However, they are expensive. They can cause anaphylactic reactions, especially the synthetic colloids. They have been associated with acute kidney injury, coagulopathy. One of the colloids, hydroxyethyl starch, has actually been withdrawn because of its high incidence of acute kidney injury and increased mortality. And again, they have not shown any difference in terms of outcome or superiority to other crystalloids. Now coming to surgical patients, so GIFT ASAP is a nice guideline that was published in 2018, and it has supported use of balanced solutions. And in a retrospective analysis of 30,000 patients, what balanced salt solution showed was difference in mortality and fewer complications. So this is a very busy slide, but there is a vast majority of work that has been done recently. And what we know now is that balanced salt solutions are actually comparable or actually better than saline and other solutions in terms of their safety profile. And I think although we haven't got the evidence right now, there is a lot of theoretical and lots of evidence that is coming out in the next, I think, a few years and now, and that is favoring balanced crystalloids as compared to saline. So after resuscitative fluids, we'll talk a bit about maintenance fluids, fluid deficit. So first of all, preoperative fluid management. So what to do when we've got a patient who's coming, who's supposed to undergo surgery. So the important thing, so we'll start with an example. So 39-year-old, 80 kilogram ASA1 patient presents to OR. His last oral intake was 8 hours ago. What is his fluid deficit? So if I ask all my residents this question, the answer that I usually get is the 4-to-1 formula. So, so we'll come to that, what the 4-to-1 formula stands, but it comes, so if we calculate the fluid, the preoperative fluid that needs to be given to this patient, it becomes about 1 liter fluid. So what was the actual deficit of this patient was about 200 ml. So just to explain this example, so if someone of my age, wakes up in the morning, the most fluid that I get after spending the night being NPO is a glass of water, so which is about 250 mLs of fluid. So where does this 4-to-1 come from? So this is called the Holliday-Seeger formula. It's a theoretical calculation that has been used since 1950s. And essentially what you do is that you, for the first 10 kg of a person, you multiply it by 4. And then for the next 10 kg, you multiply by 2. And the rest of the weight, you multiply by 1. And you add these 3 together. And the fluid that you get is a per hour calculation of the body's requirements. However, this is a theoretical calculation that has been in place since 1950s. And at that time, our understanding of fluid balance was fairly rudimentary as compared to now. And these formulas, they did not account for the increased antidiuresis during periods of illness. So our bodies in periods of stress are programmed to hold on to fluids. So we try to hold on to all the fluid that is available in the body. And actually our urine output goes down, our evaporative losses go down, there is peripheral vasoconstriction, and all of these mechanisms, there's activation of the renin-angiotensin-aldosterone system, and all of these mechanisms are there to hold on to fluids. So actually the requirements of the body decrease at that time. So what is the answer? So there's no magical answer, and all of the current recommendations that have been given on maintenance fluid are usually opinion-based. So what do you need to do? You need to assess patient. You need to go back to your basics. So you need to take a history. You need to do a physical examination, and really examining the patient. You need to look at the organs that can show you what is going on with the fluid status of patient. So don't forget your mucous membranes, don't forget your extremities, look at capillary refill, look at your mucous membranes. Are they dry, parched, moist? Auscultate your chest. Is your chest clear? Are there any crepitations? Is this patient in fluid overload? Look at is a presence of any ankle edema. So look at these signs. And if you've got an awake patient, just ask them, are they feeling thirsty? So NPO timings. So there's a vast majority of data that is coming in, and societies, the anesthetic societies are now continuously revising their NPO guidelines. So the latest guideline, for example, from the Royal College of Anesthetists and the Anesthetic Association of Great Britain and Ireland, have decreased the NPO timings of fluids to 1 hour now. So, and if you look at the American Society of Anesthesiologists, they still recommend 2 hours for fluids. So we're coming down on the amount that we want to keep a patient NPO for surgery. So make sure, and what we have evidence and what's part of major ERAS protocols. So if we minimize the time that the patient is kept NPO, the better the patient's recovery is. So hence, try to minimize the NPO timings and assess how long the patient has been NPO. So if we got patients who've been NPO for 12 to 18 hours, they are going to require more amounts of fluids as compared to patient who was having fluids till an hour ago. Bowel preparation, although it's no longer recommended by most anesthetic and surgical societies, a lot of surgeons are still using bowel preparation, and bowel preparation takes a huge toll on the fluid balance of the body. So if you've got a patient who's been bowel prepped before having a surgery, the electrolyte losses and the fluid losses are going to be significant. So how much fluid is the patient losing preoperatively? So if you've got a bleeding patient, if you've got a patient who's septic, you've got a patient who's dehydrated, emergency surgery, just think about how much fluid this patient has lost before this patient comes to you. So we need to make an assessment for that before we decide how much fluid we're going to give this patient. And we need to account for fluid shifts. So if you've got a patient who's septic, there's going to be a lot of fluid shifts. So they're going to be edematous. They're going to be vasodilated. They're going to be, whatever fluid you're going is going to go into their interstitial compartments because of increased capillary permeability. So you might have a patient who looks very edematous, but at the same time, if you measure the intravascular compartment, they're going to have a lot of they're going to be very fluid depleted. So we need to take into account are there any fluid shifts in this patient? So in terms of maintenance, we need to know what are the normal body requirements. So if a patient can't take orally, or we need to give them some sort of intravenous fluids, we need to know what their requirements are. So if in a normal patient, the normal water requirement is about 20 to 30 ml per kg. So that's about for a 70 kilo man, it's about 2.1 liter, 1.5 to 2 liter water a day. The sodium requirements is about 1 to 2 millimole per kg. Potassium is about 1 millimole per kg per day. And this is important. So 50 to 100 gram of glucose. Many people, they think if they're giving solutions of 5% dextrose or 10% dextrose, they're actually making up for the calories that the patient is not getting orally. So remember, 1 bag of glucose, 1 liter of glucose, 5% glucose bag only contains 50 gram of glucose, and a 10% glucose bag contains only 100 gram of glucose. And all this glucose does is prevents the patient from going into a stage of starvation ketosis. So it's not going to make up for the requirement of calories that a patient has if you're giving patient 5% or 10% glucose. So if we talk about post-operative fluids, again, we need to keep in mind that we need to assess these patients. So what are the things that you need to assess? Again, look at the hemodynamics of the patient. Is the patient tachycardic? Is the patient hypotensive? Examine the patient. What is the capillary refill? What do the mucous membranes look like? What is the urine output? Is the patient fluid overloaded? Does the patient have crepitations in their chest? Does the patient have ankle edema? Look at the drains. Is there drain output? Is blood coming out from the drains? What is the urine output? What is coming out in the drains? Is the patient losing fluids? So maintain the intakes and outputs. think about third spacing. So if someone has had abdominal surgery and there's a lot of tissue handling, that patient is going to be losing a lot of fluids into their third spaces. So there's going to be a lot of fluid that is going to be moving from the gut to the peritoneum and the tissues around that. So we need to account for that. Again, if this patient is septic, we need to think about these factors. So coming to what type of fluid should we use as maintenance for preoperative losses, post-operatively, what should we give? So there's not much evidence on which fluid should be used for maintenance. Generally, again, the best formula is used like for like. So if you think the patient is losing more acid and chloride, for example, someone is having upper GI losses, then you need to replace them accordingly. If someone is having diarrhea in the postoperative period, you need to give a lot of bicarbonate, you need to replace their electrolytes. So what we know is that if you give hypotonic fluids in fluids that contain sodium less than 130, it should be avoided. Patients have a tendency to develop hyponatremia more than they develop hypernatremia in the post-operative period. And the major reason for that is the use of hypotonic fluids. And again, the need for maintenance fluids should be continuously assessed. Again, one of the most important things is that keep in mind that fluids are not a natural or a substitute for oral intake. So continuously assess that. I don't know what the practices of different people around is. For example, in our hospital, what we do is if a patient has had non-GI surgery, we start giving them oral fluids while the patient is still in post-anesthesia care unit. For patients who've had routine elective GI surgery, most of these patients are started on NG feeding the next day. And then if the patients have had emergency surgery or there are signs that their balls are not working, then we wait some time to give intravenous fluids. So the need for maintenance fluids should be continuously assessed. So this article actually led to abandonment of hypotonic saline in the UK population. There were a number of deaths, especially in children, that were attributed to life-threatening hyponatremia that was caused by using hypotonic fluids. And since then, the hypotonic fluids are used less and less for maintenance. So whatever management you do, either you underfill the patient or you overfill patient, they will have adverse effects. So what happens if you give too less fluids? There'll be hemodynamic instability, understandably. There'll be decreased perfusion of tissues, tissue hypoxia, anaerobic metabolism, acidosis. And once the acid starts accumulating in the body, that leads to a vicious cycles of hemodynamic instability and worsening cellular dysfunction. So if you've got a surgical wound, it leads to poor wound handling. It leads to acute kidney injury, dehydration, and electrolyte abnormalities. So worsening electrolyte abnormalities, nausea, and vomiting. All of these effects would lead to adverse outcomes for your patients, increased length of stay, and possibly morbidity and mortality. Again, if you give too much fluids, so it's not helpful as well, and it's shown harm as well. So positive fluid balance is associated with increased mortality in septic patients. It also increases morbidity in terms of longer time to ambulation, weaning from ventilatory support, and increased time spent on ventilators, especially in the ICU population. And it leads to increased incidence of myopathies. So again, most of the work with regards to positive fluid balance has been done in the ICU population, and it has shown negative outcomes if a patient is in positive fluid balance. So I think we're coming towards the end of the talk, and we'll be talking about two things. So a lot of debate recently has centered around giving to, are we giving to, should we give uh, a little amount of fluids during surgery, so which is called restricted fluid intake? Should we use, or should we give fluid fluid in a liberal way? So give fluids, uh, so give large amount of fluids, or should we use sort of goals and monitor those goals and fluids accordingly, which is goal directed therapy? So what happens if you give too little fluid during surgery? You've got vasoconstricted vessels. So your body, if there is too less fluid, the body will try to compensate and this will lead to vasoconstriction. So if they've got vasoconstricted vessels, any anastomosis that are done, especially in the GI population, there will be poor anastomotic perfusion and there will be an increased incidence of leakage of anastomosis. So vasoconstricted vessels, too little fluids, it will impair tissue healing. So we've talked about acute kidney injury and nausea and vomiting. However, too little fluid can lead to increased risk of infections. So if we give too much fluids, what will that do to surgery? So it leads to edematous tissues. There will be an increased incidence of delayed healing. Again, increased risk of anastomotic leak. And if it's bowel surgery, there will be a delayed return of bowel function. So what is the best way to approach this? So our understanding with time is that initially most of the people were giving liberal high amounts of fluids, and then the morbid effects of liberal fluid intake were seen. And then there were lots of studies done on restricted fluid intake, and it was thought that restricted fluid intake is the way to go. However, that has shown harmful effects as well. So the best way to manage fluid is actually to go through the goal-directed therapy. And I'll just come to the evidence of that. So 2018 RELIEF trial, this was a large trial that was done on 3,000 patients, and the patients were randomized to either receive liberal or restrictive fluid. So major surgery, liberal or restrictive, and liberal fluid was defined as 10 ml per kg per hour, and restrictive patient was defined as 5 ml per kg per hour. And what they saw was there actually no difference in mortality, but the patients who were giving restrictive fluid had a high incidence of AKI. So in 2012, this meta-analysis, this is very, I think, interesting meta-analysis was done. About 2,000 patients in the perioperative look. The investigators, they looked at the goal-directed route, and the other arm was the liberal group. And what they found was that the goal-directed, the patients who got the goal-directed, who were in the goal-directed group, actually had a shorter duration of stay in hospital, and their outcomes were improved. One interesting thing that they found was that the amount of total fluid that was given in the goal-directed group was actually higher than the patients that received liberal fluid group. So it's actually not important the amount of fluid that you give to a patient, but it's important that you give the right amount of fluid at the right time, and that is what improves outcomes. So lastly, the question that should come to every anesthetic mind is, have I given enough intravenous fluids? Do I need to give less? Do I need to give more? And for these, you need to assess, first of all, assess the patient. Look at the hemodynamics. How are the hemodynamics doing? Look at the urine output. Are you maintaining a good urine output for this patient? Further than that, look at your dynamic variables. So invasive monitoring. So starting from your arterial line, if you've got a what is called a stroke volume variation or a pulse pressure variation. So essentially, if you've got a underfilled patient, you've got a variation in your stroke volume with mechanical ventilation. So if you've got a variation in your mechanical ventilation, that means that your patients will respond if you give them fluids. Look at your central venous pressures. It's going out of favor, the central venous pressure monitoring, but it's actually still a guide that you can use to measure the fluid balance. It's just that it's not the guide that you should use. So think about monitors that can use so PICO, LIDCO, and the esophageal Dopplers that can give you that can give you some information about the cardiac output, and think about things like invasive monitoring, like for example, transesophageal echoes that can give you an idea about the fluid status of the patient. Look at your lab variables. What is your lactate doing? Is your lactate rising? Is your patient acidotic? What is the hematocrit of the patient? What is the hemoglobin of the patient? Are they correlating with the patient? And that would give you sort of an answer whether this patient needs fluids or more fluids or less fluids. So what works? What do we know about? So I hope at the end of this talk, I've not confused everyone into what fluid management is. So I'll summarize what works for patient is that you minimize the NPO timings preoperatively, you minimize the stress response of the patient, you use real-time monitoring to assess the fluid status of the patient, frequently reassess where you are in terms of fluid management, and you minimize NPO timings post-operatively. And what should we be thinking about when we will go back to OR? So we should know that intravenous fluids are like any other drug. They have adverse effects, and they affect outcomes if they're not used appropriately. An understanding of physiology is important to know the effects of fluids on patient. Their use should be continuously reviewed, and overfilling of patients affects outcomes as much as underfilling. So that concludes my talk. So I'm ready for questions. There are already a few questions in.
Thank you so much, Dr. Saad. So we are open to questions now, and I would request all of my participants to kindly either raise their hands for the direct communication or to write down the comments or the questions in the chat box. So our first question is from Dr. Naseem Javed. He has also been attending our lectures previously, and he is always very keen in, knowing all the details and the evidence-based and the latest research. So I again thank Dr. Naseem Javed for joining us today. So his question is, how can we he has two questions actually. One is, how can we differentiate between fluid overload and hypovolemia? And his second question is, what is the ideal balance between crystalloid and colloid solution in the perioperative fluid management?
So thank you. So both very, very pertinent questions. So hypervolemia is a term. So hypervolemia and fluid overload are terms that have been used interchangeably. What my understanding of hypervolemia is of these terms is basically what compartment the fluid is in. So if your fluid is in the intravascular compartment, so if your fluid is in the blood vessels and you've got a higher amount of fluid that is in the blood vessels, I think that would be the term hypervolemia. Fluid overload is essentially the term that is loosely used when the patient starts developing or fluid starts going from one compartment to another. So when you've got a patient who's developing peripheral edema, or who's got fluids, who develops pulmonary edema, who's got fluid inside their lungs, it's actually easier to differentiate them in terms of terminology than to differentiate them clinically. So clinically, it's not easy to differentiate them. So for hypervolemia, the only test that I can think of that can be done to assess is assessing real-time collapsibility and the distension of the venous blood vessels. So your upper limb veins or your neck veins, your large veins, or if you can access the inferior vena cava diameter in the perioperative setting. So not so easy to do, especially if you've got abdominal surgery going on. So the next question is, what is the ideal balance between crystalloid and colloid solution? So actually, I don't think there is any balance that you give, or there's any sort of formula that you can use to calculate how much colloid should I give, or how much crystalloid should I give. So again, you need to assess your patient and essentially know what sort of losses are going on. So if I've got a bleeding patient who's bleeding quite rapidly, I think the fluid, if I don't have whole blood or blood products available, then I would probably use colloids for resuscitation rather than giving them crystalloids. And if we give large amounts of crystalloids, it does cause large amount. It can lead to high positive balance. So if I'm worried, if I have to give like 10-15 liters of fluids, I would probably add some colloid in these 10-15 liters, so that to sort of decrease the fluid overload.
Can I ask one question in pertinent to the question which Dr. Naseem had just asked? Actually, to everyone's understanding and to my understanding as well, the normal ratio, or you would say the regulation between the colloid and the crystalloid is 3:1. That on every, not on every loss, but once the blood loss has been calculated or the generalized losses have been calculated, the fluids are given according to the losses, but in the ratio of 3:1. For example, if the patient is losing blood and the allowable blood loss is, let's say, 1500, and the patient's blood loss has come to approximately 500 or 600, then obviously you always calculate, and the ratio does not meet the colloids concentration to be given, then the crystalloid is given in the ratio of, crystalloids are given in the ratio of 3 to the losses. However, if the blood loss is more than 1:1 is given. So do you have any comment on that?
So yeah, the theoretical formula is that if you're losing blood, you need to give 3 times the amount crystalloid to replace that fluid, and as compared to colloid. However, if you're giving large amount of colloids, especially, so if we talk about colloids, your FFPs, your platelets, your blood products are also colloids. So they're large molecular weight particles. So if you give large amount of synthetic colloids, you risk the running of patient into coagulopathy as well. So remember, so if you dilute your blood or the patient's blood with colloids, there is a chance of the patient developing coagulopathy, especially if you're using colloids. So remember, the blood loss, you replace like fluid with fluid. So if your patient is losing blood, I would advocate using blood products as the ideal replacement fluid.
Okay, now we have another question from Humaira Malik, and she is asking, how do you know fluid therapy for cardiac patient? Humaira, can you please unmute your mic and ask the question clearly, because the question is not clear right now.
Yes, ma'am. I would like him to answer this question, because some patients we find difficult cases, like there is patients with pulmonary hypertension, patients with pulmonary atresia, then they have patients for coronary revascularization, CABG, like that. So I would like him to answer in this way how these patients are dealt with fluid therapy.
I mean, fluid therapy in the cardiac patient, it's a whole topic in itself. However, again, there is no sort of magical answer to assess the fluid therapy for cardiac patient. So what we know is that if we've got a weak heart, or if we've got a patient who's got low ejection fractions or has got heart failure, their heart is not going to be able to tolerate hypervolemia or large amount of fluids. So what do you need to do? So again, so you need to make sure that when you're got such patient in the perioperative period, you use all the things that you have got at your disposal. So use invasive monitoring, use arterial lines, use central lines, monitor urine outputs. One thing that is very important for these patients, especially if they're going prolonged surgeries, is that you check the oxygen or the gaseous exchange in your arterial blood gases. So what are the signs that your patient is going to be going into fluid overload, especially if it's a cardiac patient? So what signs you will see is a patient that will go into fluid overload might be going into pulmonary edema. What are the signs that you will see? So you will actually see your ventilatory requirements going up. So you'll see your patients will require high amounts of oxygen, your airway pressures might go up. So there is no right or wrong answer. So what I do in these patients is, so try to have a low threshold for starting inotropic support. Monitor so if I start inotropic medications on these patients fairly early in the case, what I have got is I've got some leeway, and I can actually augment the contractility of the heart. But that doesn't mean that I'm not going to give these patients fluids. So if I have a patient whose urine output is low, whose hemodynamics are not good, I would still give them fluid, but I would just augment their cardiac output in the perioperative period.
I think this also answers the second question asked by Ramla Shahzada, that how do you give fluid to a patient with ascites and patients with the renal failure?
So just one point that I would like to add for renal failure patients is, many people think that, if you've got a patient who's in renal failure, we need to just hold the fluids, don't give these patients too much fluid. So remember, if you've got a patient who's in renal failure as well, what does that mean? That means that you need to maintain the perfusion of the kidneys. However, the kidneys might not be able to handle the load that is given to them. So the best state for a patient who's in renal failure would still be a euvolemic state in the perioperative period.
All right. So we have another question by, let me check, Rahman Ullah Jan. And he's asking why pressures of a critically ill patient drop using transportation of a shorter distance while he is adequately fluid loaded and is on support as well. So Rahmanullah Jan, can you please unmute your mic so that you can clearly and directly ask the question to Dr. Saad, please?
Thank you so much for letting me have the opportunity to ask the question. Actually, while we transport our patients, sometimes we observe that our patients have dropped their blood pressures. While we have adequately loaded them with fluids along with inotropic support, just like we observe with cardiac patients during transportation from OT to ICU, or in general ICUs for like we do CTs or other procedures. Thank you so much.
So I'm not sure I understand the question. So the pressures of a critically ill patient should not fall during transportation. So I think things to keep in mind is that when you're transporting a patient, so the things that happen is that your infusions that you're giving, so there might be so a kink in your tubing. So if you're using inotropic medications, they might not be getting to the patient. If you're giving the patient fluids, they might not be getting to the patient. One thing to remember is intrathoracic pressure. So if you're ventilating a patient during transport, so if you're so if you're ambu bagging the patient and if you're transporting that patient, so and you increase the intrathoracic pressure by giving them large amount of tidal volumes, that is going to cause hemodynamic instability as well. So the thing I think to keep in mind is when you're transporting critically ill patient is try to minimize the infusions so that so you can monitor all of the infusions, avoid unnecessary drugs at that time, and make sure if you've got an intubated patient, make sure that the patient is very well sedated, very well paralyzed. So you don't want a patient who's coughing, who undergoes desynchrony with the ventilator if you're ventilating them, because all of these things can cause hemodynamic instability.
I think this also the answer also lies in whatever you just said, that whenever someone is transporting the patient from the OR to the ICU, whether the duration is short or long, what is the recommended and the normal practice of every anesthetist is that anesthesiologist is that they give a little dose of propofol and the sedative like midazolam, or just deep give any other drug for during the transportation. So it also has to be looked upon that how much of a dose has been given before the transportation. That is also one of the causes of hypotension during the transport, whether the duration or the distance is very short. And likewise, the when the patient is being shifted from the operating room table to the transport table to be shifted to another suite like ICU or critical care, whatever area is to be shifted, then again the infusions at times they are stopped and then restarted again. So that duration of stopping the infusion of inotropes or the vasopressors, it also matters, which might not be apparent on the first reading, but in the second reading of the pressures, or while the patient is being shifted, the pressures they come down. So the timing and also the dosage are very important to be noticed. With that, we have a final remark by okay, we have another question by Danish Shams: how to confirm delusional anemia?
I think they want to ask the dilutional anemia, right?
Yeah. Yes.
So for dilutional anemia, I think I'll look at the hematocrit and compare it with the hemoglobin levels. If the so measure both hemoglobin levels and hematocrit. If they are correlating, the hemoglobin and the hematocrit. So remember, hematocrit has got more to do with with red cell aggregation. So if you've got a patient who's got a low hematocrit as compared to the hemoglobin. So normal formula that we use is that the normal hematocrit should be 3 times the hemoglobin of the patient. And if your hemoglobin and hematocrit don't match, so that means that there is some element of dilutional anemia. So there is a possibility of that. However, I think it's important not to try to make a diagnosis of dilutional anemia. And if you think the HP levels is low, then I think I would transfuse that patient, because there is, remember, dilutional anemia, measuring the hematocrit, the hematocrit and comparing it with the hemoglobin, they're all sort of theoretical they're sort of theoretical values, but however, you don't want to risk a patient going into going into very severe anemia and dropping their HP too much during surgery. So if there is any doubt, I would just go ahead and give the patient blood.
So with this, we come to the last remark. And but before coming to the last remark, Dr. Saad, one of our participant has asked, and even I want to ask, what is the goal-directed therapy? Because can you just give a little comment on the stroke volume variation, pulse pressure variation, and the leg raise test? Because you know you
Okay,
have. Yeah, just give us an insight into 3-4.
Okay, so basically, what goal-directed therapy means is that you set a goal and you give fluid according to that goal. So the normal goals that are usually set are either mean arterial pressure, your systolic blood pressure. So aiming for systolic blood pressure of 90 millimeters of mercury, or mean arterial pressure of 65 millimeter of mercury, or you set a goal of urine output, maintaining a urine output of 0.5 to 1 ml per kg per hour, and you assess and reassess, and you give fluid accordingly. So if a patient has urine output drops to 0.3 ml per kg per hour in the last hour, then you give the patient more fluid to make that up. And if it goes higher than the desired urine output, then you come down on the fluid. So you're continuously adjusting and readjusting the amount of fluid that you're giving to the patient based on goal. So how do you monitor it? So one of the aspects that is basically stroke volume variation, and that is what we use in the perioperative period. So remember, what happens is that if you've got a patient who's being mechanically ventilated, their intrathoracic pressure increases and decreases with each inspiration and expiration. So what that means is that your preload, your amount of blood that is coming into the veins and going to the heart, is increasing and decreasing with each mechanical ventilation breath. And what you actually see is a variation in the stroke volume that you can see in the form of a change in the arterial line trace curve, or you can see a change in the pulse pressure with each mechanically ventilated breath. And that actually gives you an idea that if this patient's vascular system is filled or not, or adequately or not. So if you've got a very good filled vascular system, the stroke volume variation or the variation with each breath will be minimal. And if you've got a underfilled patient, there will be a high amount of stroke volume variation with each breath. So one of the things that Dr. Asma mentioned, the straight leg raise test, is a very good test that is used in ICUs when we've got patients on ventilator, that you raise the leg of the patient and you see the response or the effect of that on the stroke volume variation. So if you raise the leg of a patient and in an intubated, mechanically ventilated patient, what you will see is that an increase in their mean arterial pressure, and increase in their pressures, and a decrease in heart rate. That means that if you increase the preload or you give this patient more fluid, the hemodynamics of that patient would improve. Another way to measure it is by doing transesophageal echoes and looking at the diameter of the inferior vena cava. So if you've got an inferior vena cava that the diameter of which variates with mechanical ventilation, that means that this patient can be given more fluids and is a bit underfilled. But if you've got a very fixed inferior vena cava diameter, that means that the patient is well filled and there's no variation with mechanical ventilation. So it's easier to do in critical care patients, but not so easy in the surgical population.
Right. Thank you so much. So we have a last comment actually by Dr. Azhar Ahmad. And he's saying that indeed a very nice and useful talk. To me, the summary is there is no ideal fluid. No fluid is superior to the other in terms of mortality. There is no gold standard method. to measure the adequacy of resuscitation. Fluid therapy varies from patient to patient and surgery to surgery, and every patient is different. So
Yeah,
is
I
that
think
the,
I think the
yeah.
last point is the most important, that you need to tailor the fluid therapy of each patient individually based on their physiology and pathology.
So thank you so very much, Dr. Saad. It was really a nice talk. And in the end, we have also shared the feedback form. So I would request everybody who has been joining us on regular basis, they know that the e-certificate is being given on the filling of this certificate. So kindly fill in the e-certificate for the feedback form so that we can get the e-certificate. And thank you so much, Dr. Saad, once again for your talk. And it was really very elaborative talk, and I really enjoyed your talk. Thank you so very much.
Thank you very much, Dr. Asma, and thank you, PSA Karachi, once again for giving me the chance.
Thank you for joining us.
Thank you.